In this sketch, we'll review 4 commonly tested childhood exanthems, which is just a fancy word for a diffuse body rash. Specifically, we're talking about measles, rubella, parvovirus B19 infection, and Roseola infantum. If that list doesn't seem exhaustive enough for you, don't worry, we've got 4 more for you. Pityriasis rosea, molluscum contagiosum, hand, foot, and mouth disease, and mumps in part 2 of this series. Check them out at a library near you. Let's begin by briefly introducing these first 4 conditions, which will be depicted on 4 different book covers from the young adult horror novel series Exanthems by R.L. Skin. First up, measles, caused by measles virus infection, previously known as Rubella. It's highly contagious and characterized by fever, rash, and the 3 C's: cough, coryza, and conjunctivitis. You'll see all things measles depicted by this poster of the first book in the Exanthems series, The Weasel Ghost. This one's a classic. Next up, we've got rubella, caused by the Rubella virus, and once upon a time called German measles. When acquired postnatally, rubella is a relatively benign disease and is vaccine preventable. The presentation, workup, and treatment of rubella will take place in and around the poster for the next book in the Exanthems series. Be careful what you rash for. Spoiler alert, don't wish for rubies. Ever. The third condition we will discuss in this sketch is parvovirus B19 infections, and goes by erythema infectiosum, 5th disease, or simply Parvo. All things Parvo will take place in and around our poster for the Exanthems book titled Monster B19. Parvo comes from the Latin parvus, for small, so we're dealing with tiny toy monsters here. Parvovirus B19 is unique in that it infects erythrocyte progenitor cells, which can cause a few unique complications. More on that later. The last condition we will cover in this sketch is Roseola infantum, caused by human herpes virus 6, and also known as Exanthem subidum, or 6th disease. The presentation, workup, and treatment of Roseola will be covered in and around the poster for the Exanthems book titled Revenge of the Rose Garden Gnomes. And don't miss the statue of Hermes for herpes virus. With that bit of intro out of the way, let's start with the haunted tale of the ghost weasel. Due to successful vaccination efforts, measles was declared eradicated in the United States in the year 2000, but due to a decrease in vaccine uptake, significant outbreaks have taken place around the U.S. Those most at risk include anyone that has not been vaccinated, and is depicted in the poster by a broken banister that looks like a broken syringe. This includes infants too young to be vaccinated, those unable to be vaccinated for medical reasons, those that have not received the second dose of the vaccine, and those who have refused the vaccine. The classic presentation of measles is an erythematous maculopapular rash that starts at the head before spreading inferiorly to the rest of the body. This is represented by the red candle dripping maculopapular dots of wax onto a gargoyle from head to toe. Measles is highly contagious and is spread through respiratory secretions that may remain airborne for up to 2 hours, represented by the airborne moths drifting away from the ghost weasel. As a result of this, susceptible individuals can become infected from merely entering a room that had an infected patient in it up to 2 hours earlier. Making it even worse, infected individuals are contagious from around 5 days before the emergence of the rash, and remain so until about 4 days after it appears, making it almost impossible to limit its spread. There are 4 clinical stages that describe measles progression. The first of these is the incubation period, which lasts 1 to 3 weeks, and is depicted by the number 3 in ink. Get it? Incubation in the upper right-hand corner, where the poster is dog-eared, like you're seeing a page number. The second stage is known as the prodrome, and is characterized by fever, depicted by the candle flame behind the ghost weasel's head, and the 3 C's: cough, coryza, and conjunctivitis. You'll see that our ghost weasel has 3 C-shaped buttons on his robe, and that he's coughing, has a drip of snot coming from his nose, and has glowing red eyes. You know, he's not snarling, he's sneezing. Ain't no real threat there. The third and most characteristic stage of measles is the exanthem stage, This consists of the emergence of an erythematous maculopapular rash, like we already mentioned. It starts on the face that spreads downward to the trunk and extremities. Other characteristic findings seen during the exanthematous phase include a high fever, depicted by the high red candle above our gargoyle, and pharyngitis, represented by our gargoyle's glowing red mouth. The final stage is known as the recovery phase, with clinical improvement beginning around 48 hours after the rash first appeared. You can expect to see desquamation of the heavily affected skin areas, depicted by peeling yellow lichen on the second gargoyle statue on the floor. The rash lasts 7 days and fades in the order it appeared, from head to toe. You'll see that our second gargoyle also has wax on the lower half of its body, as if the wax has been dripping down the statue, just like the rash would dissipate. Individuals that contract measles retain lifelong immunity after recovery, depicted by the shield on the wall with a large I for immunity. There are also several complications associated with measles that you will need to know about. These include diarrhea and otitis media, which are the most common, and pneumonia, which is the most common cause of measles-associated death. You'll notice that these complications are all depicted by the young kid that is attempting to outrun our weasel specter. Specifically, diarrhea by the brown puddle he's splashing through, otitis media by him plugging his ears, and pneumonia by the dirty lung-shaped spots on his chest from splashing in the puddle. You'll also notice that this unfortunate kid is wearing a brain hat that is on fire to represent another complication, encephalitis. Although rare, it can be rapidly progressive and lead to long-term neurodevelopmental issues, or even death. The last complication you will need to know about is subacute sclerosing panencephalitis, or SSPE for short. SSPE is a progressive neurodegenerative disease of the central nervous system and is not well understood. It is unique in that it typically occurs 7 to 10 years after a natural measles infection, and although progression may vary, it is universally fatal, underscoring the importance of vaccination. You'll see this depicted by the tagline on our book poster, which reads, "After 10 years, the specter appears." Emphasis on SSPE. Alright, that about covers the presentation of measles. For the physical exam and beyond, let's get back to the physical world of the bookstore and meet up with some young readers. Before examining the little guy or girl you suspect has measles, infection control measures will need to be put in place, including airborne precautions, which are represented by the child wearing an airborne bomber jacket beneath the poster. These precautions include placing a mask on the patient to limit the spread of respiratory droplets, see mask he's wearing, and all staff wearing N95 respirators to filter out airborne particles, see the helmet he is wearing, which is labeled N95. Patients should also be placed in private rooms that will remain off limits until at least 2 hours after the patient's departure. You will then need to complete a thorough skin exam that includes exposing all areas of the skin to ascertain its progression, checking skin turgor to assess hydration status, and checking for blanching, which is present in the early stages. You can see this represented by our young pilot, who is so terrified by the book he's reading that he's managed to squeeze the color out of the cover. You will also need to conduct a careful mouth exam to look for dry mucosa and Koplik spots. These spots are typically seen on the buccal mucosa opposite the molars and are described as grains of salt on a red background. They are represented by the spots on the inside of the arms of the couch, which looks eerily similar to the inside cheeks of a huge mouth. You will also want to conduct ear, lung, and neurological exams to identify any complications such as otitis media, pneumonia, and encephalitis. Despite these unique findings, a diagnosis of measles requires a few different lab tests that are represented on the pilot's frightened friend. These tests include a positive serologic test for serum measles IgM antibodies, see her stylish IgM earrings, the detection of measles RNA with PCR, see her poly-colored chain necklace, and the isolation of measles virus in culture. The only thing more horrifying than the Exanthems series is a book about culture. In cases where encephalitis is suspected, a lumbar puncture can confirm the diagnosis. The CSF will usually show increased protein with high amounts of lymphocytes and normal glucose levels. While imaging is not required in typical measles cases, it may be used to identify suspected complications, specifically a chest X-ray for pneumonia and a brain MRI for encephalitis. Whenever you are considering a diagnosis of measles, be sure to keep in mind other causes of childhood rashes. This includes Roseola, Parvo B19, Rubella, and scarlet fever. The absence of the 3 C's and Koplik spots may indicate measles is less likely. Check out the differential diagnosis menu for a more in-depth look. Once you have made the diagnosis of measles, treatment in uncomplicated cases primarily consists of supportive therapy, represented by the fluffy pillow our third kid is using to support his back. This includes antipyretics, fluids, and the treatment of bacterial superinfections such as pneumonia and otitis media. In cases of severe measles, such as those that require hospitalization, low vitamin A serum concentrations have been observed. In these cases, vitamin A should be administered, as it has been associated with decreased morbidity and mortality. In certain groups at high risk of mortality, patients have been shown to benefit from treatment with ribavirin, illustrated by the black shirt with a rib cage design.
Emphasis on the RIB of ribavirin.
This includes the treatment of measles pneumonia in patients less than 12 months old, patients greater than 12 months old with measles pneumonia that requires ventilatory support, and in patients with severe immunosuppression. Given its highly infectious nature, you are required to report all measles cases to the public health department so that the potential spread of the virus can be averted, hence the carrot-loving kids book report. These kids will also need to be excluded from school or work until at least 4 days after the onset of the rash, just like this kid, who is too cool for school. Lastly, you'll see that in addition to eating a carrot, our kid is busy writing his report with a pen that looks like a syringe. This illustrates that all contacts that have no evidence of prior immunity should be vaccinated immediately to prevent infection and limit its spread. All right. That weasel ghost is really giving me the willies. I think we should move on to book 2.
Be careful what you rush for.
Featuring Ruby, the fortune teller. Like measles, rubella was declared eliminated in the United States in 2005, with all identified cases being attributed to recent immigrants from countries where it is still present, or to unvaccinated people that have traveled to those countries. If you look behind the crystal ball, you'll see another broken banister that looks suspiciously like a broken syringe. Rubella is characterized by the emergence of an erythematous maculopapular rash that spreads rapidly from head to toe. While this progression is very similar to what we talked about with measles, in rubella the rash spreads inferiorly much more rapidly. Just think of these maculopapular rubies showering down on our unfortunate wishmaker in the crystal ball. Rubella is transmitted via respiratory droplets, illustrated by the droplets of goo dripping from the Exanthems title, and is contagious from several days before the onset of the rash until about 2 weeks after. That's a lot of droplets. Rubella also has an incubation period of 2 to 3 weeks, which is depicted by the number 3 inked in the right-hand corner of the dog-eared poster. Unlike measles, rubella often has a very mild clinical presentation, and in some cases is completely asymptomatic other than the rash. This is represented by the smiling face of the young girl on the other side of the crystal ball. Apparently, she doesn't know what is in store for her. In cases where there is an identifiable prodrome, it typically consists of a low-grade fever, illustrated by the low candle giving a luminous glow to the young girl's face. During the exanthematous phase, the defining rash begins as a pinpoint erythematous maculopapular rash, like the pinpoint tips of the rubies, that begins on the face before extending down to the trunk and extremities, like I mentioned, and then beginning to clear after about 3 days. Although it is uncommon in children, you may see polyarthritis in some cases, depicted by the knee and elbow pads our young skateboarder is wearing. While complications of rubella are rare, they include encephalitis, which is depicted by the flaming brain tarot card on the table. Back to the physical world for the physical exam. When it comes time to examine a little guy or girl you suspect may have rubella, you will want to put in place some infection control measures, specifically droplet precautions, which requires a face mask, gown, and gloves. You will need to complete a thorough skin exam that includes exposing all areas of the skin to identify the pinpoint erythematous rash and its progression. You should also feel for lymphadenopathy, especially in the posterior cervical, posterior auricular, and suboccipital lymph nodes, as these are considered a hallmark of rubella. See how the young reader clutches her pearl necklace? Lastly, you'll also want to complete an oral exam to look for Forsheimer spots, which are rose-colored spots that may appear on the soft palate and are unique to rubella. If you look closely, you'll see that this couch also resembles a mouth, and that there are red dots on the soft palate backrest. Given that rubella's presentation is so similar to other viral exanthems, its diagnosis should be confirmed with a serum rubella IgM assay, hence the ever-popular IgM earrings. In addition, you may see thrombocytopenia, which is represented by the broken plates on the table near the crystal ball, and which can lead to hemorrhagic complications in very rare cases. Once you suspect a diagnosis of rubella, be sure to keep in mind some of the other causes of childhood rashes. This includes measles, hand, foot, and mouth disease, roseola, and scarlet fever. Feel free to check out the differential diagnosis menu for a more in-depth look. Once you have made the diagnosis of rubella, treatment consists entirely of supportive care, depicted by another fluffy yet supportive pillow. Like measles, all confirmed cases of rubella need to be reported to the public health department to prevent its spread. See book report sticking out of her backpack. And, until the exanthem has cleared, all susceptible individuals should be kept out of contact with the patient. This includes exclusion from school for a week after the appearance of the rash. All right. Don't wish for pointy gems. Got it. What's next in the Exanthem series? Oh, right. The Parvo-sized monster B19. Parvovirus infection is most commonly seen in school-aged children, represented by the backpack on the floor. Outbreaks most often occur from late winter to early summer. Let's symbolize the middle ground here with some spring flowers. The characteristic presentation of parvo is the emergence of an erythematous facial rash, which is typically described as having a slapped cheeks or butterfly appearance. You'll see this depicted on the possessed parvo-sized toy men in the midst of a slap battle, with rosy red cheeks to prove it. The parvovirus is primarily transmitted through contact with respiratory droplets, which is again illustrated by the drops coming from the Exanthems book title. However, the virus is stable in the environment, which means fomites are also a significant source of infection, and is depicted by the toy car being held by the kid in his room. While parvovirus has an incubation period of 1 to 2 weeks, see the number 2 inked in the corner behind the dog-eared poster, it is contagious from 5 to 10 days after exposure, and remains so for 5 days, meaning that most kids are no longer infectious by the time the rash appears. Not as many droplets this time. When kids do become symptomatic, it typically presents with mild, non-specific systemic symptoms, such as fever, coryza, headaches, and myalgias, shown here by the tissue box on the floor. After a few days, the characteristic erythematous slapped cheeks rash appears, like I mentioned, often with a circumoral pallor, depicted here by the painted-on white mouths of the possessed toys. Over the next several days, they will develop a maculopapular rash on the extremities and trunk. See the spotted shirt? The rash gradually fades into a lace-like reticular rash, depicted by the lacy red curtains on the window. The rash spares the palms and soles, hence the clean sole of the kid's foot. He better not step down, though. One unique characteristic of Parvo B19 infection is that this rash will often recur with exposure to the sun, changes in temperature, exercise, and stress. Stress, specifically, is represented by the stress reliever squeeze toy. Parvo can also occasionally present with arthralgias, illustrated by our mint condition skeleton toy with wrapped joints, although this is more common in adults. The most significant complication of parvovirus infection is aplastic crisis, which occurs as a result of the destruction of erythroid progenitor cells. In healthy individuals, this loss of cells has a minimal effect, but in those with an increased turnover or a decrease in red cell production, this can result in aplastic crisis and severe anemia. A plastic crisis. This is most commonly seen in those with sickle cell anemia, but can occur in those with spherocytosis, thalassemia, and iron deficiency anemia. Hey, at least that sickle-brandishing aplastic skeleton toy isn't coming to life. Yet. Physical exam time. Use droplet precautions again, and complete a thorough skin exam. You'll want to look for the slapped cheeks rash on the face, as well as the lacy rash on the extremities and trunk, which can help you to differentiate it from other exanthems. You should also look at the palms and soles, as these areas are typically spared. Also, given the risk of anemia or aplastic crisis in those with sickle cell anemia, you'll want to check for signs of anemia, such as pallor by looking at the mucous membranes of the mouth and inner eyelids, and signs of weakness or lethargy. While a presumptive diagnosis can often be made by clinical features alone, it should be confirmed with a serologic test for parvovirus B19 specific IgM and IgG antibodies. There are those earrings again. In cases with aplasia, a diagnosis can also be made through the detection of parvovirus B19 DNA with PCR. And there are those polycolored chains again. Those are still cool, right? You may also want to check a complete blood count, or CBC, to look for a decreased hematocrit or hemoglobin concentration, or a decrease in the reticulocyte count. After your evaluation, when you begin to suspect a diagnosis of Parvo B19, be sure to keep in mind the other causes of childhood rashes. This includes measles, roseola, rubella, and scarlet fever. And check out the differential diagnosis menu for a more in-depth look. Whoa, am I the only one with deja vu? Once you have made the diagnosis, treatment primarily consists of supportive care with NSAIDs and antihistamines, depicted by the pillow the young reader is using for support in her beanbag chair. Makes sense? The one exception to this is in cases where a plastic crisis occurs, and a red blood cell transfusion may be required. Since most kids are no longer infectious by the time the rash appears, they should not be excluded from school, depicted by the toy school bus on the bookshelf. All right, let's move on to the last book in the Exanthems series for today, featuring more little creepy things. Roseola primarily occurs in children before 2 years of age, shown by the flamingo lawn ornament shaped like a number 2. The defining presentation of roseola is the onset of a high fever, hence the big elevated gnome torch. The fever lasts 3 to 5 days and is followed by a diffuse maculopapular rash that emerges as the fever abruptly resolves, and is represented by the diffuse maculopapular rose petals. While roseola has an incubation period of less than 2 weeks, see the 2 inked in the corner, the human herpes virus 6 is primarily transmitted through the asymptomatic shedding of virus in the secretions of close contacts, seen here as rose petals that have fallen into the puddle secreted from the fountain. It is thought that virus shedding is lifelong, as permanent as those rose tattoos on the gnome's arm. Nice. While roseola will typically present with the abrupt onset of fever as high as 104 Fahrenheit, remember, big torch, children will also be otherwise well-appearing, with the fever typically lasting 3 to 5 days before undergoing rapid defervescence. This is illustrated by the second gnome's extinguished torch. This is also the time that the maculopapular rash on the trunk appears, which then spreads to the face and extremities. You'll see this illustrated by the fact that our first gnome has red petals on his trunk, while our second gnome has petals on his trunk, his creepy little face, and even his creepy little arms and legs. While roseola usually has a benign course, febrile seizures are not uncommon due to the rapid nature of fever onset. The book's tagline, "When they're waking, you'll be shaking," can help you remember the shaking seizure. All right, back to the physical world for the physical exam. As always, when it comes to rashes, you will need to do a complete skin exam that includes exposing all areas of the skin. Specifically, you will be looking for the characteristics of the rash and how it is spread. You will also want to check for blanching of the rash, as it is characteristic of roseola, and is represented by the frightened girl squeezing the color out of her red book. Check for any cervical, postauricular, and occipital lymphadenopathy, which is commonly seen in roseola and is illustrated again by the nodular pearl necklace. One last time for good measure. During your evaluation of a child with suspected Roseola infantum, be sure to keep in mind other causes of childhood exanthems. This includes rubella, measles, scarlet fever, and Parvo B19. Once again, feel free to check out the differential diagnosis menu for a more in-depth look. Roseola is a benign and self-limited disease, just like how garden gnomes are benign, self-limited creatures. Treatment consists of supportive therapy, including antipyretics for fever if it is associated with discomfort. Lastly, a child with Roseola should return to school once the fever has been gone for 24 hours, even if the rash is still present, hence the last school bus toy. Alright, let's wrap up this sketch with a brief review of what we've learned. Measles is characterized by an erythematous maculopapular rash that starts at the head before spreading inferiorly and is typically seen in the unvaccinated. It is highly contagious and spread through respiratory secretions that can remain airborne for up to 2 hours and thus require airborne precautions to be put in place. It has 4 clinical stages, starting with an incubation period lasting 1 to 3 weeks, followed by a prodrome, which includes a fever and the 3 C's, cough, coryza, and conjunctivitis. The exanthematous phase consists of a high fever, with the rash which spreads from the face to the trunk and extremities, and may include pharyngitis. The last stage is the recovery phase in which clinical improvement occurs, with desquamation and the rash fading in the order it appeared. Complications include diarrhea and otitis media, which are most common, and pneumonia, which is the most common cause of measles-associated death. More dangerous complications, which are much rarer, include encephalitis and subacute sclerosing panencephalitis, which occurs years after an infection and is universally fatal. On exam, you will see blanching of the rash, as well as complex spots on the buccal mucosa. The diagnosis of measles requires a confirmation via serology, PCR, or viral culture. Treatment primarily consists of supportive care in uncomplicated cases, but may require vitamin A replacement in more severe cases and ribavirin in cases where there is a high risk of mortality. All confirmed cases of measles need to be reported to the public health department and excluded from school. All close contacts with no evidence of immunity will also need to be vaccinated. Rubella is characterized by the emergence of an erythematous maculopapular rash that spreads rapidly from head to toe, more so than measles. It is most commonly seen in the unvaccinated and is transmitted via respiratory droplets, and thus requires droplet precautions to be put in place, with most cases having a very mild or asymptomatic presentation other than the rash. Cases with an identifiable prodrome typically include a low-grade fever, followed by the rash spreading from the face to the trunk and extremities before clearing after about 3 days. Polyarthritis may also be seen, although it is rarer in children. Complications are rare, but can include encephalitis. On exam, you can expect to see lymphadenopathy as well as Forsheimer spots on the soft palate. The diagnosis of rubella should be confirmed with serum rubella IgM assay. The treatment of rubella primarily consists of supportive care, and all confirmed cases need to be reported to the public health department. These patients should be excluded from school and kept out of contact with susceptible individuals. Parvovirus B19 most commonly occurs in school-age children during the late winter to early summer. It is characterized by an erythematous facial rash that is described as a slapped cheeks rash. Parvo is spread through contact with respiratory droplets and, in some cases, fomites, which requires contact and droplet precautions to be put in place. It will typically initially present with mild systemic symptoms, with the slapped cheeks rash appearing a few days later, followed by a maculopapular rash on the trunk and extremities, which fades into a lacy-like reticular rash that spares the palms and soles and can recur with stress. The most significant complication of parvovirus infection is aplastic crisis with severe anemia, which occurs in those that have increased red blood cell turnover, such as sickle cell anemia. While Parvo B19 can be diagnosed clinically, it can be confirmed with serology or PCR. Treatment consists primarily of supportive care. Kids should not be excluded from school, as by the time the rash appears, they are no longer infectious. Roseola infantum is caused by the human herpes virus 6 and is characterized by a high fever lasting 3 to 5 days before undergoing rapid defervescence, followed by a diffuse maculopapular rash that emerges on the trunk as the fever resolves. This rash will then spread to the face and extremities. Roseola primarily occurs in children less than 2 and is spread through secretions. It typically has a benign course, although febrile seizures can occur due to the rapid nature of fever onset. On exam, you will want to look for blanching of the rash, as well as posterior lymphadenopathy. Roseola treatment typically consists of supportive therapy, with children being able to return to school once the fever has been gone for 24 hours. Now that you are all suitably frightened by the living embodiment of your nightmares, I think we should take a quick break from the giant ghost weasels and dead-eyed gnomes that will totally not be watching you when you sleep. See you in part 2.